Assalamu alaikum. So it's an honor to moderate this grand round for the lecture by Professor Ahmed ElAsrar titled Diabetic Retinopathy. Professor ElAsrar doesn't need any introduction. He's one of the highest cited researchers, one of the 2% in the world who's highest cited research, and he has more than 200 papers. Without further ado, Professor Ahmed.
شكرا مروان, الله يحفظك. شكرا. Today I'm going to discuss diabetic retinopathy. In fact, this is the same lecture, more or less the same lecture that I gave last 25th of November by the invitation by the Royal Belgian Academy of Science. That was the invitation by the Royal Academy, and this is the building of the Belgian Royal Academy of Science. It's a palace, and this palace was built by the Dutch king before Belgian independence in year 1820. And Belgian independence was in 1831. So King Leopold I, he donated this palace to the Royal Belgian Academy of Medicine to support science. And I gave this lecture in this palace. It was very impressive even from inside. So diabetic retinopathy is still a major public health problem, especially here in the country. It is the most common and specific complication of diabetes, and is still a leading cause of visual impairment and even blindness in the adult working population worldwide. The global population with diabetes mellitus is estimated to be 463 million in year 2019 and projected to be 700 million in 2045. Among individuals with diabetes, the global prevalence of diabetic retinopathy is 22.2%. And when it comes to vision-threatening diabetic retinopathy, defined as severe non-PDR, proliferative diabetic retinopathy, and the clinically significant macular edema is 6%. For clinically significant macular edema, which is a major cause of moderate visual loss, is 4%. Therefore, in year 2020, the number of adults worldwide with diabetic retinopathy is estimated to be 103 million. Vision-threatening diabetic retinopathy, 29 million. And the clinically significant macular edema, 19 million. In year 2045, the numbers are projected to increase to diabetic retinopathy, 160 million, vision-threatening diabetic retinopathy, 45 million, and the clinically significant macular edema, 29 million. The prevalence of diabetic retinopathy is highest in Africa and North America and the Caribbean, and lowest in South and Central America. Hispanics and Middle Easterners with diabetes are more likely to have diabetic retinopathy compared with Asians. If you compare type 1 and type 2 diabetes, the prevalence of diabetic retinopathy is higher than type 1 diabetics compared to type 2 diabetics. Not only this, but it is well known that the complex fibrovascular proliferation is more severe in type 1 diabetics compared to type 2 diabetics. And I can tell you, currently, every other week, I'm personally operating a 22-year-old, 24-year-old type 1 diabetic with end-stage diabetic traction retinal detachment and very aggressive traction retinal detachment. This data on clinically significant macular edema especially is important because of the wide use of anti-VEGF agents. So this is important for global health care guidelines, and resource planning. The demand for diabetic retinopathy and the clinically significant macular edema treatment will continue to increase significantly in the future. So what are the risk factors for diabetic retinopathy? Longer duration of diabetes is, of course, a non-modifiable risk factor. You cannot modify it. It is estimated that by 20 years of diabetes, 6% of type 2 diabetics will have some sort of retinopathy, and almost all type 1 diabetics will have retinopathy. But the modifiable risk factors are higher hemoglobin A1C, higher blood pressure, and dyslipidemia. Regarding pathogenesis of diabetic retinopathy is not only a microangiopathy. It is also neurodegenerative disease. And even neurodegeneration is an early event, even before the appearance of microvascular lesions. And this is related to hyperglycemia and altered metabolic pathways that lead to oxidative stress. There is significant impairment of the neurovascular unit. So what is the neurovascular unit of the retina? It is composed of neural cells, ganglion cells, bipolar cells, amacrine cells, horizontal cells, glial cells, molar glial cells, astrocytes, microglia, and vascular cells, endothelial cells, and pericytes. The components of the neurovascular units are in intimate communication to maintain the integrity of the inner blood retinal barrier. It is nowadays, it is well established that there is a state of chronic low-grade inflammation present in the retina in diabetic patients. And this plays a key role in damaging effect to the neurovascular unit. In the animal model of diabetes, the most famous animal model is tryptozotocin-induced diabetes in rats. Within 2 weeks of inducing diabetes, there is increased adhesion of circulating leukocytes to microvascular endothelium, a process called leukostasis. This, of course, will lead to damage of retinal vascular endothelial cells and the breakdown of the inner blood retinal barrier and capillary non-perfusion. It is well established that this process of leukocytic stasis is associated with increased expression of adhesion molecules by retinal vascular endothelial cells. The most famous is ICAM1, or intercellular adhesion molecule 1, and the leukocyte integrin CD18. In fact, in the animal model, it is well shown that if you block ICAM1, you block the process of leukostasis. When it comes to proliferative diabetic retinopathy, we have 3 major components involved in the initiation and progression of the disease. And these are ischemia-induced retinal angiogenesis, inflammation, and fibrosis. We and the others described the local production of growth factors and their receptors, pro-inflammatory cytokines, chemokines, adhesion molecules, and matrix metalloproteinases. The most famous angiogenic factor is VEGF, which is strongly upregulated in this disease, mainly produced by molar glial cells. And it is not only angiogenic factor, but it is also hyperpermeability factor that lead to breakdown of the retinal barrier. We showed that leukocytes, the presence of leukocytes in epiretinal fibrovascular membranes excised at the time of Barthélemy vitrectomy to repair traction retinal detachment, provide pro-inflammatory and pro-angiogenic factors. In addition, we showed a strong positive correlation between the number of monocyte macrophages in the epiretinal membranes and angiogenesis activity. This suggests a strong mechanistic link between inflammation and angiogenesis. And this is currently a very hot area for research, is to find the link between inflammation and angiogenesis in diabetic retinopathy. I'm going to show you some examples of immunohistochemical analysis of pre-retinal membranes, pre-retinal fibrovascular membranes excised from the retina during Barthélemy vitrectomy to repair traction retinal detachment. This is a negative control. So the upper one is a negative control. What does it mean, negative control? You do the same staining procedure, but you omit the primary antibody just to check the integrity of the staining. And this is staining for CD31. CD31 is a marker for endothelial cells. So what you see here, all these are neovascularization, abnormal new vessels present in the epiretinal membrane. And we always count during studies these new blood vessels to give us an idea about the macrovascular density so that we can talk about angiogenic activity. And this is CD31 in a membrane which the disease involuted. During surgery, that was only white fibrous tissue, and then you will see less new vessels, but here you have membrane from patient with active angiogenesis type of surgery. The inflammatory component, as you can see here, is manifested by many leukocytes expressing CD45. Then we have a special interest nowadays in monocyte macrophages and the pathogenesis of the disease. And this is standing for the monocytic marker CD68. And then you can see many monocyte macrophages. Monocyte macrophages are belonging to two different phenotypes, M1 phenotype and M2 phenotype. The M2 phenotype is the one involved in fibrosis and angiogenesis. And then we did studies to look at this. The markers for the M2 phenotype is CD206, and you can see that the majority of monocyte macrophages expressing the marker for M2 macrophages. And also, M2 macrophages express CD163. And again, you can see that majority of the cells in the epiretinal membranes are belonging to the M2 phenotype. And this is very important information that we'll discuss later. Now, the fibrogenic component is manifested by the presence of many myofibroblasts. Myofibroblasts are the cells that control fibrosis by releasing extracellular matrix protein. And this is standing for alpha-smooth muscle actin, showing many spindle-shaped myofibroblasts. This is fibroblast-specific protein 1, and this is fibroblast activation protein alpha. Fibroblast activation protein alpha is of special interest because it is a marker not only of myofibroblasts but also of activated myofibroblasts. So the presence of fibroblast activation protein alpha indicates these positively stained cells are activated myofibroblasts. The grading of the disease, it is well known that it is graded into non-proliferative disease, mild, moderate, severe, very severe, or proliferative disease characterized by the formation of new vessels, pre-retinal membranes, vitreous hemorrhage, traction retinal detachment, rubiosis iridis, and angle new vessels. It can be early without high-risk characteristics or with high-risk characteristics. The advanced disease is characterized by traction detachment involving the macula or vitreous hemorrhage obscuring the ability to grade NVDs or NVEs. The vision-threatening stages are, of course, diabetic macular edema, severe non-proliferative retinopathy, and BDR, and these are examples of macular edema with cercinet rings. So venous abnormalities is the most important and most reliable sign of severe non-proliferative diabetic retinopathy, and you can see here the venous beading. And venous looping also is a sign of severe non-proliferative diabetic retinopathy, and this is showing the correlation between retinal ischemia, as shown by fluorescein angiography, and venous beading. Proliferative disease, new vessels on the optic nerve head, or it can be also elsewhere, as you can see here, and associated with severe retinal ischemia, fibrovascular proliferation. This is bilateral disease in this patient at presentation. And believe me, this is a 18-year-old girl who came with very aggressive fibrovascular proliferation and pre-retinal hemorrhage, and I operated already her left eye. Fibrovascular proliferation, which will cause traction retinal detachment. Screening. So what is the purpose of screening? The only way to prevent blindness in diabetic retinopathy is to do screening for diabetic patients. The objective of screening is to detect vision-threatening disease before it becomes symptomatic. The time that the patient comes to the emergency room complaining of reduced vision because of hemorrhage or traction retinal detachment or chronic macular edema, it is too late to save sharp vision. So screening is needed to preserve the vision of these patients. Screening is cost-effective, currently performed by digital photography and telemedicine. However, nowadays there is a lot of interest in artificial intelligence and deep learning algorithms. Regarding artificial intelligence, there are numerous devices around. Some of them are good, some of them are bad. Some of them, they have good performance. Therefore, there is an urgent need for head-to-head validation studies. It may be cost-effective, may significantly reduce the screening burden of diabetic retinopathy. Nowadays, we are conducting a study in our department using a system of artificial intelligence to validate this system by comparing our clinical examination with artificial intelligence systems that we are currently have. So what is the medical management? Management of diabetic retinopathy is not only treating the eye, is not only injecting or doing laser. You have to treat the patient as a whole. You have to look at the control of blood sugar and the blood pressure and dyslipidemia. Many important studies show that intensive treatment of glycemia reduces the development and progression of diabetic retinopathy in type 1 and type 2. Intensive control of blood pressure was effective in type 2 diabetics. The use of fenofibrates are cholesterol-lowering agents and lipid-modifying drugs that was shown to reduce the progression of diabetic type 2 diabetes. It has been shown that the effect of the fenofibrates is not only related to the cholesterol-lowering effect and lipid-modifying effect, but it has a beneficial effect not related to this. The use of angiotensin-converting enzyme inhibitors was shown to retard the progression of diabetic retinopathy in type 1 and type 2. Now, few words about what's called metabolic memory and the importance of this metabolic memory. The diabetes control and complications study that was multi-center study in the United States and Canada, they randomized patients with type 1 diabetes to two groups. One group continue with conventional treatment, and the other group will have tight control, and the mean hemoglobin A1C in this group was 7.2%. At the end of the follow-up, at about 6 years, it was very clear that tight control protected the retina. Then after the termination of the study, these patients that were included in the study were followed up in another study called the Epidemiology of Diabetes Intervention and Complications Study. And through 4 and 10 years of follow-up, the risk of diabetic retinopathy progression was greatly reduced in the former intensive group despite equivalent levels of hemoglobin A1C. Despite the fact that two groups already after the study had the same hemoglobin A1C, after 4 and 10 years, the previously tightly controlled group is still protected. By year 18, progression of diabetic retinopathy, progression to proliferative diabetic retinopathy, and the clinically significant macular edema need for intervention continue to be lower in the former intensive group, and this is called metabolic memory. These data are very important because it tells us it is very important to give the patient tight control early in the course of diabetes. This will continue protecting them in the future. Laser photocoagulation is still a major line of treatment, both for macular edema and for proliferative and severe non-proliferative retinopathy by PRP. Intravitreal injection of anti-VEGF agents used for clinic macular edema involving the center of the macula, intravitreal injection of corticosteroids, and vitreoretinal surgery. This example of a patient with chronic macular edema before and after focal laser photocoagulation. You can see within 6 months, hard oxidase will absorb. Pan-retinal photocoagulation. This is for proliferative disease and severe non-proliferative retinopathy. In fact, when I started here doing retina, I thought that PRP is a simple technique. Everyone should be able to do it. But nowadays, one of the major causes of blindness that we see is that many of these patients, they receive partial treatment. It seems that even among colleagues who were trained in retina, they are not able to do full PRP. and the full PRP is vision saving. I think we still need to do more efforts to train fellows to do good PRP. The PRP should be complete, as you can see here. I put these two examples, that it should extend from the disc up to the far periphery, from the arcus up to the periphery, and you leave 2 disc diameters temporal to the macula and extend to the periphery. We still need to teach residents and fellows how to do PRP. Vitreoretinal surgery, for like in this patient with advanced diabetic traction retinal attachment before and after surgery. This excised tissue, membranes, this is the tissue that we use for our research. Anti-VEGF agents, the currently available drugs are ranibizumab, bevacizumab, and aflibercept. Aflibercept is currently available in 2 doses, 2 milligram, 8 milligram. Now, the 3 drugs are equally effective if the patient presents with visual acuity better than 20/50. But if the vision at presentation 20/50 or worse, it was shown that aflibercept might be more effective. Faricimab is a recently available drug. It is the first drug that can target 2 pathways. It is bispecific monoclonal antibody that will target both vascular cell growth factor and angiopoietin-2. Brolucizumab is also recently available. However, we are not interested in this drug because of the several reports of severe intraocular inflammation after its use that lead to blindness. Now, intravitreal anti-VEGF therapy is not optimal. You have to give many injections. The effect is transient. And one recent review showed that despite monthly injection, 40% of the patients with macular edema fail to respond. So what does this mean? Anti-VEGF agent treatment is not working in all patients. During the last year retina, I had discussion with Professor Medina that we need to have new biomarkers to tell us if this patient can respond or not. And perhaps the non-responding patients are those who have severe inflammation. So that means that other pathways beyond the VEGF as a result of inflammation are existing. And the molecular mechanisms beyond VEGF should be explored to develop new therapeutic targeting VEGF-independent mechanisms. So we should know that there are some patients who respond, these are VEGF-dependent, and some patients do not respond, these are VEGF-independent. So we have to find what are the molecular mechanisms beyond VEGF that we need to target. And this is the subject of our research in our laboratory in collaboration with Reagan Institute for Medical Research. So nowadays we are focusing to identify new molecules that can be used as a target for treatment. And one of the first molecules, in fact, it was our discovery in our lab, high mobility group box 1. High mobility group box 1, you can see we published about this 11 papers. We showed that it is a very potent pro-angiogenic, pro-inflammatory, and also it induces neurodegeneration. It is, in fact, a nuclear protein. Under stress, it escapes into the cytoplasm and then outside the cell to act as a pro-inflammatory and a pro-angiogenic cytokine. And this is one of the papers about high mobility group box 1. And the title was Association of High Mobility Group Box 1 with Oxidative Stress Markers and Regulation in BDR. So high mobility group box 1 was an important biomarker. Then we studied also proteases, matrix metalloproteinases. And of course, when we talk about matrix metalloproteinases, this is of course done in collaboration with Professor Abdunakar. Professor Abdunakar, his laboratory is mainly dealing with metalloproteinases. So we published 12 papers. And one of these papers was on differential expression of ADAMTS. This is subgroup of proteases. And metalloproteinases mediate diabetes-induced retinal neuropathy and vasculopathy. Metalloproteinases are involved in both neurodegeneration and the diabetic vasculopathy. Also, one of the papers that I like very much this paper, that the title was a functional link between matrix metalloproteinase 9 and prominin 1 in diabetic retinal vasculopathy and neuropathy, and other papers. We also were the first group to look at inflammatory chemokines. Chemokines are serving both inflammation and angiogenesis, and this was the first paper published to show the role of monocyte chemotactic protein 1. In fact, many papers after this paper that was published in 1997 confirmed our results. Then we looked at, in this group of papers, on the pro-inflammatory and pro-angiogenic pathways. We have like 24 papers. This is one of the last papers in which we evaluated the CD40 ligand pathway in proliferative diabetic retinopathy. Regarding neurodegeneration, our paper was the first one to show neurodegeneration in the post-mortem retina of human subjects without microvascular disease. So these patients, it was documented in their files that they don't have diabetic retinopathy. And then we looked at the presence of apoptosis markers in the retina. Now I'm going to discuss in some detail one of these papers just to illustrate to you the strategy of our research. This is a paper in which we examined the potential role of a molecule called MEF, or macrophage migration inhibitory factor. So the title of the paper was the pro-inflammatory and the pro-angiogenic macrophage migration inhibitory factor is a potential regulator in proliferative diabetic retinopathy. Now, just to give you an idea how we look at these new biomarkers, we always do screening in the summer in the lab to look at human tissue like vitreous, peritoneal membranes, and to look for molecules that have the potential to be involved in both inflammation and angiogenesis. And then once we identify one of these molecules, then we do in-depth studies using the animal model and tissue cultures. So macrophage migration inhibitory factor is widely expressed pro-inflammatory cytokine. It acts through a receptor called CD74, and activation of the receptor will cause activation of several signaling pathways, including ARC1 and 2 and nuclear factor kappa P. Also, it acts on two chemokine receptors, CXCR2 and CXCR4, meaning that it has chemokine-like activity to induce leukocyte chemotaxis. In addition to its role in inflammation, MEF has a major role in angiogenesis. This has been proven in cancer research. It induces angiogenesis. Its upregulation will make the tumor more aggressive. Based on this, we decided to study MEF in proliferative diabetic retinopathy. And our results showed the following. By immunohistochemistry, we showed that MEF was strongly expressed by vascular endothelial cells. The red is the positive staining. This is active membrane, and this is involuted membrane. Also, it is expressed in spindle-shaped myofibroblasts. By colocalization studies, it was expressed by leukocytes. You remember when I was talking about pathogenesis that leukocytes bring into the eye pro-angiogenic and pro-inflammatory factors. Receptor also CD74 was also expressed by endothelial cells, as you can see here, by spindle-shaped myofibroblasts and also by leukocytes. Statistical analysis showed that there was significant correlation between the macrovascular density as estimated by the number of pathologic new vessels and the expression of MEF and its receptor. We did also ELISA analysis for the vitreous samples from patients with diabetic retinopathy obtained during surgery and compared it with non-diabetic control. And the MEF was strongly upregulated, and in addition to VEGF and soluble ICAM. We always use for the analysis VEGF as an angiogenic biomarker and soluble ICAM as inflammatory biomarker. And there was strong significant correlation between the levels of MEF and levels of VEGF, levels of MEF and the inflammatory biomarker soluble ICAM1. Then we wanted to see the CD74, the receptor. CD74 receptor was examined in the vitreous by using Western blot analysis, and you can see in BDR they have stronger signal compared to non-diabetic control. So it was upregulated in proliferative diabetic retinopathy. Then we wanted to see if MEF can induce VEGF. So we treated molar glial cells. Remember, I just said that molar glial cells are the main producers of VEGF in the retina. These are the major source of VEGF. So we treated molar cells with MEF with different concentration. And you can see that at the concentration of 100 nanogram per ml, MEF strongly upregulates the production of VEGF. So it means that MEF is upstream of VEGF. Now we wanted to see if MEF can induce signaling pathways in molar cells. So MEF, as you can see here, strongly upregulated ARC, phospho-ARC. So it means that it can induce signaling. And signaling is important to produce cytokines and chemokines by molar cells. Then we wanted to see if molar cells can produce MEF. So if we induce molar cells with hypoxia, we could show that MEF is upregulated. And of course, hypoxia will induce production of VEGF by molar cells. So molar cells can produce MEF. So MEF can induce VEGF by molar cells, and exposure of molar cells to hypoxia induces MEF. Then we did in vitro angiogenesis assays, and we demonstrated here that compared to VEGF, MEF is also can produce endothelial cell chemotaxis, which is essential step for angiogenesis. Compared to VEGF, MEF also can induce endothelial cell proliferation. So MEF was as potent as VEGF in inducing in vitro angiogenesis. Then in the animal model, in the rat model, we wanted to see what happened in the eye, in the retina, if we inject MEF into the vitreous of normal rats. Then we could show here that MEF could induce breakdown of the blood retinal barrier. And the MEF could induce phospho-ARC and nuclear factor kappa P. And MEF could induce VEGF. MEF could induce the adhesion molecules ICAM and VCAM. So in conclusion, we demonstrated that the pro-inflammatory and the pro-angiogenic cytokine MEF and its receptor CD74 are upregulated in the intraocular microenvironment of patients with BDR, particularly in patients with active angiogenesis. Intravitreal administration of MEF significantly increases retinal vascular permeability. It works like VEGF. MEF stimulation of molar cells induces increased secretion of VEGF, and the hypoxia induces the production of MEF from molar cells. Stimulation of human retinal microvascular endothelial cells with MEF induced migration and proliferation, and these are key steps for angiogenesis. Based on this data, the MEF CD74 signaling pathway might play an important role in proliferative diabetic retinopathy, angiogenesis, and the progression, and could become a primary therapeutic target to improve the vascular function in patients with proliferative diabetic retinopathy. The second study that I'm going to discuss, because this is also in another direction, this is also recently published last year, that the title of the paper is that tissue inhibitor of metalloproteinase 3 ameliorates diabetes-induced retinal inflammation. We are also interested inside the eye, there is a balance between angiogenic and anti-angiogenic factors. And if this balance is disturbed in favor of angiogenesis, then pathologic angiogenesis will happen. Why we were interested in TEMP? Because TEMP is anti-angiogenic. And we wanted to see if TEMP is present in the eye, TEMP3, and at what level. And if we enhance these levels, could we reduce the inflammation in diabetic retina? In the family of tissue inhibitors of metalloproteinases, there are 4 groups: TEMP1, TEMP2, TEMP3, TEMP4. And these inhibitors block the action of matrix metalloproteinases. But not only this, they have also cytokine-like activities. They have other functions. TEMP3 is unique among this group because it has a broad spectrum. It has also anti-inflammatory effect. It has also anti-angiogenic effect. It blocks the binding of VEGF to its receptor, VEGF receptor 2. So it has both anti-inflammatory effect and anti-angiogenic effect. In a previous study, we looked at the levels of these 4 TEMPs in the eye in the samples from patients with diabetic retinopathy. And TEMP3 was expressed at very low levels and not upregulated in diabetic vitreous compared to non-diabetic controls. So we hypothesized that by augmenting the levels of TEMP3, by enhancing its level in the eye, we can treat diabetic retinopathy. We did Western blot analysis of the vitreous, and we showed that TEMP3 is present as 2 bands, 30 kilodalton and 24 kilodalton. You see the predominant band, the strongest band is the 30 kilodalton. So what is the 30 kilodalton band? This is glycosylated TEMP, and glycosylation of TEMP stop its effect. So what we have in the eye is already glycosylated and not effective to block VEGF. In the animal model of diabetes, this is streptozotocin-induced diabetes in rats. This group of rats, diabetic rats, received only phosphate buffer saline as a control, and this group of diabetic rats received intravitreal TEMP3. And TEMP3, and this is a control, and TEMP3 significantly reduced the breakdown of the blood retinal barrier. Also, intravitreal injection of TEMP3 in diabetic rat reduced the expression of the inflammatory signaling pathway nuclear factor kappa B. Intravitreal injection of TEMP3 in diabetic rat significantly reduced the adhesion molecule ICAM1 and also VEGF. So it inhibited or attenuated diabetes-induced inflammation and angiogenesis by down-regulating VEGF. In molar glial cells, if you treat molar glial cells with high glucose, they release a lot of VEGF just to mimic the diabetic condition. If you pre-treat the cells with TEMP3, you inhibit VEGF production. If you expose molar cells to hypoxia, then you will produce a lot of VEGF and also inflammatory chemokine MCP1. But MEF blocks this. Sorry, TEMP3 will block this. The same for tumor necrosis factor alpha. During the course of diabetes, there is also, as I said, there is activation of signaling pathways and exposing Muller cells to high glucose upregulate ARC phosphorylation, and TMP3 blocks this. During diabetes also, there is increased apoptosis of Muller cells. They die. And by high glucose, there is increased expression of the apoptotic marker Caspase-3, and TMP3 protect. ADAM17 is known to be an activator of tumor necrosis factor alpha. It's a major pro-inflammatory cytokine in diabetic retinopathy. And the MEF prevented ADAM17 upregulation by high glucose. As we discussed earlier, that an important finding in diabetic retina is leukostasis, or increased adhesion between circulating leukocytes and endothelial cells. And the TMP3 blocked this, and the block 10 of alpha induced adhesion between circulating leukocytes and endothelial cells, and VEGF induced adhesion of circulating leukocytes. In angiogenesis assays that were done in Leuven, TMP3 prevented VEGF-induced angiogenesis. Remember, one of the actions of TMP3 is that it blocks angiogenesis by blocking the interaction between VEGF and its receptor, VEGF receptor 2. So based on this finding, we suggest that by upregulating the intraocular levels of TMP3, we can ameliorate diabetes-induced retinal inflammation. Thank you very much for your attention.
Thank you, Professor ElAsrar. I would like to open the floor for discussion or questions. I remember when I once joined you in your lab in Belgium, you were working on the
In fact, neurodegeneration is much earlier phenomenon than microvascular disease. Start much earlier. That's why diabetic patients, they lose contrast sensitivity very early. Their night vision is affected early. So neurodegeneration is an early phenomenon.
Is it a prerequisite to the ischemia, or is it?
I don't think so, but the retinal neurons tend to die and to suffer because of oxidative stress very early in the course of diabetes, before microvascular disease.
And are there any molecules that have been studied in order, for example, to suppress this neurodegeneration?
I don't think there are studies that were done, but I think the most important is tight control of blood sugar.
Any questions? Dr. Tariq?
Thank you, Prof. ElAsrar, for the usually excellent lectures. Just my question is regarding those patients with, let's say, vision-threatening diabetic retinopathy, severe non-PDR or PDR, that for the sake of discussion that we do for them full PRP, but many of them, they actually still progress with fibrovascular proliferations, with recurrent vitreous hemorrhages and so on.
Tara, in my experience, if you do full PRP at the stage before fibrosis, I mean, if you do it the stage of severe non-PDR or PDR with just new vessels, the outcome is excellent. But if you do PRP at a stage of fibrovascular proliferation, there is already fibrovascular tissue developing on the retina. I always say that presence of fibrous tissue on the retina is like a time bomb. At any time when BVD starts, the patient will have recurrent bleeding and can have retinal breaks causing combined detraction, remotion detachment, or pure traction detachment. So we need to treat this patient with PRP at the stage before In fact, if the patient presents with fibrovascular tissue, it's already too late. We need to treat them before fibrosis starts. This is the same like for ROP.
I do have a question. If you have a type 1 diabetic and an old patient who's type 2, and both are the same grade, like severe or say early PDR, and you do parenteral photocoagulation to both of them, same intensity, we commonly see that the type 1 PDR would sometimes, after an initial resolution, will go on and progress, and he will come to the ER with fibrovascular tissue or vitreous hemorrhage in spite of full PRP. Would this be explained by metabolic memory?
I don't know, but the observation, I have seen it in few patients. But first of all, full PRP is protective. But some of these patients with type 1 diabetes, even with full PRP, the fibrovascular proliferation continue to spread. And the treatment here is to do vitrectomy. And I did this few times. One of them was a relative of our colleagues, type 1 diabetic. Full PRP, you can also try to help this by injecting anti-VEGF agents if it is at the stage of only new vessels. But if they continue to proliferate on the surface of the retina, vitrectomy will stabilize this. Of course, vitrectomy and separation of the pseudohyaloid.
Dr. Sousan?
Yeah, thank you very, very much for a beautiful lecture and for your hard work on this. I have one comment and two questions, if you don't mind. In the old age, when we didn't have anti-VEGF treatments and where we used to do PRP and heavy PRPs, quite extensive PRPs, there were some patients that did not respond enough, as you have just mentioned. And at the time, we used to take them to the OR and depress the anterior retina that we could not reach with the slit lamp and do additional PRP on the retina up to the aura and sometimes even the posterior part of the pars plana. And in most cases, that would do it. That would stabilize the patient. Now with anti-VEGF, of course, once you've done a very good PRP, anti-VEGF usually helps if you still see the proliferation, or if you still see the angry looking eye, which is like the congestion of the veins and the dotum blood hemorrhage is still in the periphery and so on. So that's my comment. I have two questions. The first question is, there is no doubt that inflammation plays a role in diabetic retinopathy and particularly in diabetic edema. And from your insights and your work, where do you see steroids helping in diabetic macular edema? That's my first question.
Let me answer this one first.
Yes, sure.
As I said, we always start with, we do both. Laser, especially with circinate rings, focal leakage, and if the center is involved, we give anti-VEGF agents. And most of the patients, they respond to this regime. We only inject if the patient are not responding, and especially in pseudophakic eyes. I don't like to inject. We have few bottles of Elovin, fluocinolone acetonide, long-lasting, that lasts for like 3 years. And we use it in few patients who are pseudophakic with excellent outcome. So I think the primary treatment should be anti-VEGF agents and laser. And then if the patient is not responding, then we have to give steroids.
Yeah, I agree with you fully. I'm just questioning from a scientific...
I want to add here that Eduardo Medina, he is doing a study in his department looking for inflammatory biomarkers. And those patients who are having high levels of these inflammatory biomarkers, he go for steroids from the start. But we need to have reliable biomarker to tell that if this patient is VEGF dependent or inflammation dependent.
Yeah, I agree with you. I also think that some patterns on the diabetic macular edema that you see on OCT, particularly those who have the very, the very big chunks of exudation and lots of disruption of the inner retina, I think those probably would respond by giving steroids earlier than later. I've also done a study years ago on the long-term evolution of diabetic macular edema after triamcinolone injection. This was in 2006. And at the time, we didn't have Ozurdex, as you know. So we used to give triamcinolone. And in the beginning, the results were very good. And then with time, the results kind of disappeared, and we got the opposite, actually. But the only category, because I have, at the time, categorized patients into by visual acuity, not by patterns of edema, but by visual acuity. The only patients in my study at the time that benefited on the long run with steroids were the patients who had 20/200 or worse vision, and those were the ones who had the worst edema. So I think it makes sense, to start with that. But my question, Dr. ElAsrar, was, what is it about the steroids? Where do the steroids fit scientifically with all the the markers that you have studied inflammation? Where exactly do they work?
If the patient, as I said, 40% of the patients using anti-VEGF agents, you don't respond. That means that there is another pathway beyond the VEGF that we need to find. And that's why we do all these studies. Yeah. We need to, for example, angiopoietin 2, which is now targeted by faricimab. In year 2007, the British Journal of Ophthalmology, we wrote the first paper on the expression of angiopoietin 2, angiopoietin 1 and 2, and Tie2 receptor in diabetic retinopathy. That was the first paper. And we showed that angiopoietin 1, as you know, angiopoietin 1 is a good angiopoietin. It stabilizes the retinal blood vessels. And the angiopoietin 2 is the bad one, which destabilizes the blood vessels. And both of them, they act on Tie2 receptor in the endothelial cells. And we showed that the angiopoietin 2 is upregulated, and the angiopoietin 1 is not existing in the eye of patients with diabetes, meaning that angiopoietin 2 at that time, in our opinion, was an important target. And that is now shown by faricimab. So we need to find other pathways. This is not only VEGF. We should find other pathways beyond VEGF. And I think faricimab was a drug in the right direction because it targets both VEGF and angiopoietin 2. And I didn't mention during the lecture because of the sake of time that the ideal treatment will be a treatment that will target several pathways, not only one.
Yeah, for sure. Okay. My other question, if time permits, is that there is a very small minority of patients who have diabetes for a very long time and who have no diabetic retinopathy.
Yes.
Do you have an explanation?
Yeah, no.
And they're not necessarily poorly controlled.
Yes.
I'm perplexed. I don't know what's going on. Do you?
We have many patients like this.
Many?
Yes.
I have maybe a handful, maybe 5
because
patients.
I am seeing many colleagues from the College of Medicine who come to us to look at their retina. And I know some of them, they have diabetes for 22 years, 25 years. Yes. I don't want to mention names, but they don't have retinopathy. Yes. And their hemoglobin A1C is not very tightly controlled.
True. Anybody who has an idea why could this be genetic?
Could be.
Is there something that we don't know?
Could be.
There is a paper by Dr. Fauzan Kraye regarding a paper by Dr. Fauzan Kraye that looked into the genetic predisposition of developing diabetic retinopathy. So he took patients who have more than 20 years of diabetes without any diabetic retinopathy or barely minimal. And he studied those patients. He published it in Human Genetics.
And what was
I don't know the specifics. It's genetics. So.
Okay.
I provided patient for him, but
Actually, I did provide patients
you
to
too,
him
and Dr. Aboud, yeah.
as well, except that I didn't realize that he published it, nor do I know what he discovered. But that's okay. I'll look into it. Thank you very much. Okay.
One last question or comment?
We can go to the